So welcome back to my channel. If you guys don't know me, my name is Allie and I've been a hospice nurse for approximately 8 years. So in this video, we're going to go over the types of wounds we see in our hospice patients, our more common types of wounds we see in our hospice patients. We are going to go over how we assess these wounds and how we treat them, how we manage them, and along with management is also somewhat of prevention so that we don't get more skin breakdown. So let's get into it. I need to put a disclaimer in here that this is not to cure, diagnose, treat. This is not medical advice. This is just based off of my personal experiences as a hospice nurse. But let's dive into the types of wounds that we commonly see in our hospice patients. So we're going to go with first, obviously, pressure ulcers. That's what they're called. I'm going to go with the pressure ulcer, also known as the decubitus ulcers. Now, these wounds are traditionally found on our bony prominences on our patients that are bedbound mostly, who have incontinence and decreased nutritional status or low nutritional status, all things that contribute to forming decubitus ulcers. So we want to generally look at our patients who are high at risk for skin breakdown, who are in these situations that have these risks, and we are going to assess them on their bony prominences for skin breakdown. Our scale that we use to do that is called a Braden scale. Insert here. I'm going to have to do some major editing on this video because I'm tripping over my words today. So now the second type of wound that we commonly see in our patients is called a skin tear. A skin tear occurs mostly in the extremities of our older population. They get very fragile skin. All of us know that as we get older, our skin becomes thinner. So that's why it's more easily torn, bruised, etc. What happens is patients will maybe rub up against the corner of a furniture or a wheelchair. I had one person who gave herself a skin tear by putting on pantyhose, and she had long fingernails and tore all the way up her shin. A skin tear, when you have a partial thickness skin tear, a partial thickness skin tear is when that dermis separates from, when the epidermis separates from the dermis. The full thickness wound is when the epidermis and the dermis separate from that underlying tissue. So that's full thickness. Another common wound that, why is my lamp shaking? So another common wound we find with our hospice folks is venous stasis ulcers. So those normally occur on the lower extremity. Those usually occur on the lower extremity below the knee. They do look like this. They can last up to a month, if not more, depending. We have risk factors such as immobility, poor venous valve function or dysfunction, I should say. So we also see diabetic foot ulcers or diabetic ulcers. They normally occur on the lower extremities, the feet. Arterial ulcers. Now, we talked about venous stasis ulcers. We're going to talk about arterial ulcers. Arterial ulcers normally look like this. And again, our folks with cardiac diseases are more at risk for developing arterial ulcers. It's another type of chronic wound we deal with. They do have a little bit different of a look, if you notice, than the venous stasis ulcers. They almost look like a punch out, like different, but like kind of along the same lines of insufficiency. Our cardiovascular system is very important, along with our GI system. I just have to put that out there. Now that we've gone over the type of wounds that we usually see, we're going to get more in depth with our pressure ulcers first. We have about 4 main stages, and then we have an unstageable stage. So stage 1 looks like this. The skin is reddened or pink. It's non-blanchable. When I say blanchable, I mean if you press down on something, it turns white and that redness comes back. It shows that that circulation is coming back. When something is considered non-blanchable, it will be red or pink. You push down, it stays red or pink. You pull up, stays red or pink. Change in that circulation there. We are looking specifically for, though, in a stage 1, that it is non-blanchable. This is not medical advice. This is just how I practice it. But if I have a patient who has an area that looks pinkened and it is still blanchable, I'm going to keep my eye on it. Push down on it. Check to see if that bad boy is blanchable. That is why it is so important to do a head to toe. If your patient wears oxygen, check behind those ears, please. Check their cheek. They do have little pads. So again, if it has an area where it can cause pressure, check it. So I'm going to put this as an aside. Be like a nursing professor right now. It's an aside. It's not going to be on the test, but this is just something to keep in mind. It's always on the test though, right? Something that is what we would qualify as a deep tissue injury. That is not going to be a pink or a red color. We're going to look at that and see that it's more purpley, more maroon. Deep tissue, think deep purple. Pressure, pink, deep tissue, deep purple. Is that a thing? Can we make that a thing? Now, let's move on to the next stage of our pressure ulcers. We're going to look at our stage 2s. Still not looking so great, right? We're not looking so hot. We've broken through that epidermis. Where we're going to start doing and applying our wound care. Things that we can do for this, put an Optifoam there as a way to put some cushion there. So we're seeing a break in the epidermis layer right now. The wound bed, though, you're not seeing that S card. It's a little angry, though. They can have drainage, so you're going to want to note how much drainage it has. Oh, we're going to go on to our stage 3. So stage 2 is partial thickness. Stage 3, we're going full thickness. It's where you're going to see adipose tissue, otherwise known as fat tissue. You're going to see some granulation, which is that like sprinkly white stuff. For granulation, okay, you got to watch out for that. That's something to also note. It won't be on the quiz, though, I promise. We're not getting quizzed. You're not getting quizzed. You're going to have, you might have slough. You're also going to, where I also watch out for tunneling and undermining. No, we're not going mining. This is not Minecraft. To assess tunneling, undermining, you use like the clock, right? Do you remember that? Kind of locate and give people an idea of where that tunneling and undermining is. We do use the sterile Q-tip because our little sterile Q-tips should have measurements on them. This you can use for wounds, but it also helps when you are looking for tunneling, especially. When we put our little Q-tippy in, we're gonna note where it lands and where it stops. Then we're gonna measure how long our undermining is. It gives us also an idea of how much we will need to pack that wound. So again, when I see a wound like this, I'm gonna make note of the width, depth, length. They do have wound. They have wound measurements that are specifically circular. Moving on to stage 4. These ulcers can go all the way down to the bone, right? We're talking full thickness. Full thickness. Yeah, it's deep. The deepest one I've ever been in went, I swear, my whole hand up to my wrist. It was a sacral pressure ulcer. It did not happen on our service. You're going to probably see, you have to check for we have to check for undermining, tunneling. You're going to maybe see some eschar. The edges are going to look curled in. It's going to look irritated probably around the peri wound, which is another thing to keep in mind when you're assessing these things. This is our full thickness one. This is basically the last stop on the choo-choo train before we get to the unstageable. Moving on to the unstageable. So yeah, you're thinking unstageable, like how do you not know? Well, it's because the actual wound is obscured by like eschar. So like we don't know what's under it. So a large portion of how we determine what stage a pressure ulcer is by what tissues are exposed. Apple. It's almost like peeling an apple, right? Where are we? Maybe it's a potato or an onion. Onions have more layers. Maybe it's like an onion. We have eschar that is blocking our view. We can't tell what's underneath the eschar. The final wound we see is going to be, did I talk about deep tissue injuries? I'm going to put this as an aside, I guess, because I think I'm losing my mind. The skin is intact, but you see that purple maroony color. You know, it occurs over bony prominences on all of those places where we would find normal pressure injuries. The skin's not open. It's just like literally everything's under the surface there. So it can look shiny as well. And again, you're going to see that dark maroon, purpley color too. So we're going to go over how we manage these wounds in the home, and kind of what products that I see or I use in my practice. I'm going to go about this as we're going to go from like bottom to top. So like the bottom layer of the wound dressing up to like our secondary dressing, like our main one that covers the top, the whole cherry on the cake. Okay. So the first one we're going to use, this is for autolytic debridement. This is a product called TheraHoney. You may have seen it. They have some of these in your local drugstores now. And if you're looking at TheraHoney and you thought moist wound healing, you would be correct. It's sticky. And it has a scent to it. So make note of that I make note of that. I like to I look at a patient's orders before I go in because a lot of these patients I haven't seen before. And if they're using TheraHoney, I want to make note of that because it can kind of, deter away from the original smell or odor of that wound. I do like using the sheets better than the sticky stuff because it's less messy. But sometimes you got to use the stuff in the tube because not every wound is going to be suitable for a sheet of TheraHoney. I have never used a TheraHoney impregnated dressing before. You know, oftentimes if a wound needs some debridement, like if we need to get rid of tissue that we don't want there, TheraHoney is great. So this can be used on wounds that have scant to copious drainage. When we use the TheraHoney, though, we're like trying to pull stuff out of the wound because the wound is not doing it on its own. Usually, like if a wound's heavily draining, you just want to use like a very good second. If you need to debride, you want to use a secondary dressing, or we use a secondary dressing like Optifoam, like something with good absorption. And sometimes that might need to be changed every day. As long as we get our wound to debride to get rid of that tissue we don't want so that we can kind of progress that healing process, let's go. And just note that there might be some products that I don't mention just because I haven't used them out myself. So I'm not going to speak on things that I haven't used. Here's my favorite one. This is my calcium alginate OptiCell. You can have silver infused into these bed areas. It's pretty fancy. When they get the silver in it though, expensive. It gets expensive. So this is, like I said before, this is for our heavily draining wounds. You get the ones in the silver. I guess it can like kind of spread out like the release of the silver too. So that helps manage odor as well. And like I said, it helps to wick away that drainage so that we can get better healing out of that wound bed, right? It also helps manage the bacterial burden. So inflammation, infection, boop, boop. So we also use a thing called Quick, Q-W-I-C-K. I don't know why they can't spell it like how it is. So this is used on our moderate to heavily draining wounds. Absorbs drainage. These things are non-adhesive too, so no stickiness. Neither is the calcium alginate. When you feel it, it's thick. Boop, boop, boop. It's like a little sponge. I've also seen like collagen wound dressings used, not often though. It looks like this, so this is like wound edge type stuff, I guess. I don't know, I wish I could apply these to my face. I wonder if that would work. Usually we use this for like slow healing wounds, which I feel like is every wound, but like again, I've only seen it in practice like a handful of times. So now we're gonna get to, let's see, things that we do for before we get to our main dressing. I just punched my mic. When I like apply my let's say I apply my calcium alginate, I cleaned it all out, right? Did little circles with my gauze, boop, toss it away, make sure to maintain that. And then I apply like my calcium alginate, let's say. I usually cut it to size. I try to cut it to size so that we don't like kind of, so if we're trying to wick away moisture, right, from the wound, we're not going to wick away that moisture onto the peri wound. We don't want to do that because we want to kind of maintain our peri wound as much as possible. The way we're going to protect that wound bed, sometimes we can use a barrier cream around it. But especially when you are applying a dressing to like a place, when I apply a dressing to a place that is in like a moisturized area, a moisture moisturized environment, heavily moisturized environment. What am I saying? I'm saying words. So what I do is I apply that, what was I going to say? I apply Sure Prep, that's what it's called. Thank you. Prep to the place where I'm going to stick that bandage. So you want to make sure, like what I do is, well, what you have to do in order for it to work is you got to let it dry. So usually it comes in a wipe like this. I think it also can come in a stick or a Q-tip. So we applied the Sure Prep and we're on our way. Now we're going to go on to our like final stage possibly of wound care, which is like our secondary dressing. Like Optifoam. They also have bordered gauze. Looks like this. Not my favorite for our folks with fragile skin. Yeah, let me know what you think, but I find it is very hard to take off. Yes, you can get things to help remove adhesive that becomes very irritated with adhesive. There are ways, like we have Optifoam that does not stick. Just the pad, and we can wrap that with like acrylics. But we do have Optifoam Gentle. We have Optifoam with silver in it. Like we have all sorts of Optifoams. They come in all sorts of sizes, shapes. We even have ones that are custom for like the heel. Again, the sacral dressing one that looks like this. It's like a kind of a weird heart. What does it look like? It kind of looks like the pelvic bone. Does it not? I don't know, maybe. That's our like main form of dressing. And like I said, it comes in a variety of sizes. You can stick that pretty much anywhere you want. And you can order them singular, in packs, in boxes, depending on how much you're going to change that dressing. And what's nice about Optifoam, if anyone's ever used it, or if anyone hasn't used it, the backing is like a kind of a plasticky, not plasticky, but it's supposed to be waterproof. Now we're going to get into the assessment of these wounds, how we're going to like manage these wounds in the home or wherever your patient lives. Okay, so then we're going to look at our wound. Eyes on the wound. We're going to look at that wound bed. Is it moist? Is it dry? What kind of environment also does it hang out in? Is it a moist environment? Is it a dry environment? Next thing we're going to also look at is drainage. Copious? Scant? How much of the dressing is saturated? If I put that dressing on like 3 days ago, because yes, some of these dressings can stay on up to 3-5 days, depending on the drainage. So, or the drainage of the wound, excuse me. So we also need to note that when we're looking at drainage and charting how much there is, because like if there is a little amount of drainage, or I should say, if there's a copious amount of drainage, let's say 100% of the dressing is saturated, I think to myself, well, this dressing was changed yesterday. That for sure is copious. When we assess the wound, we're going to look for where it is. We're going to use our markers, right? If they have a lot of wounds, you're going to need to use more specific markers, especially if you have to measure them. That's what I try to do at least. And we're going back to A&P with those anatomical markers. So the next thing, obviously, that I've been saying this whole time, we're going to measure the size of it. So length, width, depth. Obviously, we're going to want to stage the pressure ulcer, right? We're going to want to stage the wound that you should know. And my charting system prompts us to do this. So you have to note the peri wound. So intact, indurated, firm, edema. And we've already talked about the drainage, right? If it does have drainage, what does the smell like? Okay. Sometimes it'll be a foul odor. Sometimes it won't be any odor. But if there is a foul odor, I think I've talked about this in a video a long time ago. I've come so far from my first videos. But if there is a foul odor, I note, like, can I smell it when I walk into the room? Sometimes you can. Sometimes you can't. Always note any pain, whether that be pre-wound care, during wound care, or when you finish the wound care. Sometimes, I have patients that we pre-medicate prior to wound care because it can be extensive for some folks. Let's move on. We're going to go on to the final part of our video, which is prevention, which is what we want to do. Of course, well, let's go back to the basics, right? Like what I always tell people, ask is like, how often is this person, especially if they're bedbound, how often are we repositioning them? It should be every 2 hours, right? We use pillows for repositioning. I like to show folks how we can utilize our things in the home for repositioning. Now, I've had patients too who do favor sides, right? Like he was always a back sleeper, or she always slept on their left side, or whatever. It can be hard to kind of get those people off of those areas so that we can foster healing to the places that are now broken down because they favor sides. You got to try. So aside from repositioning, which is kind of like our first, kind of education that we do, we also can get like alternate pressure mattresses or low air loss mattresses that kind of alternate that pressure and take it off certain areas. So patients, especially those who are bedbound, super great. We can get foam overlays. We can get gel overlays, wheelchair seat, like a gel seat, cushion. We can get different cushions, things like that. So yeah, we can do that. You can do things like we do things like make sure that our heels are, floating the heels. I show people how to like roll up, a Chuck's towel or use pillows or whatever, and make sure we are floating those heels to take pressure off of them. You can also get what we call booties. They look like this. Aren't they glamorous? That have like little holes in the heels too, and holes around like our bony prominences to just keep the pressure off of them. Another thing that we can do for prevention is to utilize like all of our fun barrier creams, like silicone ones, dimethicone based ones. You can mix them. You can do whatever you want. Create potions. So other basics that we use to prevent skin breakdown, like prompt incontinence care. I know people are like, you're wild for thinking that happens. Oh, I am crazy. I know it's not always optimal and not everybody has the manpower or like the time to do prompt incontinence care, but like we should really try. Also, another thing is making sure the like sheets, everything that's under the patients is not wrinkled. I know another thing that's like near impossible, but like even a little wrinkle in the sheet to some of our folks can be enough to start a pressure injury. So that makes me bring on to my next point, or move on to my next point, which is about like applying briefs. We all know what briefs are. If you call them a diaper, I'm not going to talk to you. On an adult, these are briefs. And so our folks who use front closure briefs, so when I refer to a front closure brief, we have a pull-up brief, then we have a front closure brief. Front closures have those tabby tabs. So we're not going to want to like squeeze the heck out of the material. If our patients are snug in a bug and a rug and those briefs, maybe they're too small. Like if we're finding we're having to pull tight the material over the patient just to get that brief closed, probably want to size up. But yeah, we're going to want to make sure like everything is like spread out like it looks. We're not going to want it all like bunched up. Everything should be flattened out. Like flattened out, no wedgies, like what the sheets think. No, we don't want wrinkles in our briefs, right? Keeping it dry. So like even when you're doing a bed bath on a patient, like I want to make sure my patient's dry after, especially after like pericare too, and the wipes. I like want to make sure that stuff is dry before I wrap them. Yeah, let me just show you this though. This is a little thing before we go. And no, I don't know where to get these. This is a Medline. It's called Advanced Wound Healing. It's great. It's a great little pocket guide. It says at the top, it even shows you like what type of wound it is and the products they have. I need to get a new one. Like you can't just buy these. I've looked on Amazon a majillion times to see if I could put them as a link in my bio so people can get their own, but definitely ask your wound care nurses to like, or your clinical manager or whoever does the ordering, like, can we get some of these in our office? Yes, you can get a PDF of this. I'll try and remember to put the link down below. This is a nice tangible thing. It makes more sense to keep this in your bag too, right? So if you don't already follow me though on the TikTok or Instagram, you got to, no, you don't. I'm just kidding. You can stay with me here on YouTube. I don't care if you follow me here on YouTube. Oh, hold on. Hey guys, sorry that got cut off. My little one called from her dad's and now I am recording and ending on a different day. But I just want to let you know there will be a part 2 on that, and it's going to be what wound care looks like in the setting of home hospice. So that is different because we're not doing wound care at a facility. So it's in a less controlled environment. I would say maybe sometimes a totally out of control environment. And what does it look like when we utilize everything that we have just talked about in this video in somebody's house? So stay tuned for that. And until then, if you're bored, you can definitely watch all my other videos. Thanks for watching. Bye.